Begin by inspecting the head position and facial features.
Okay.
The patient's head should be held upright and still. Check the shape and symmetry of the eyelids, eyebrows, palpebral fissures, nasolabial folds, and mouth at rest and with movement and expression. These facial features may be slightly asymmetrical, but should have no edema, coarsening of features, lack of expression, or other unusual changes in appearance.
Okay, if you could look straight ahead, I'm going to observe your face.
In an older patient, the eyelids may look wrinkled and hang loosely, and soft bulges may appear under the eyes. Next, inspect the patient's skull for size, shape, and symmetry.
I'm going to be touching your hair and scalp.
Also examine the scalp, parting the hair and working systematically from the frontal area to the occipital area. You should see no lesions, scaling, or evidence of parasites. Next, palpate the skull from front to back, using gentle rotary movements. The skull should feel symmetric and smooth, with no tenderness, swelling, or depressions, and the scalp should move freely over it. Also, palpate the patient's hair. Its color, texture, and distribution should be appropriate for the patient's age, gender, and ethnic background. In men, hair loss may occur at the temples or crown of the head with age.
And now I'm going to
Then palpate the temporal arteries, which should have no thickening, hardness, or tenderness.
I'm going to listen to your arteries too.
If you suspect a vascular anomaly in the brain, use the bell of your stethoscope to auscultate the temporal area. You should hear no bruits on either side. Slide your fingers down to the temporomandibular joint space in front of the tragus. As the patient opens his mouth, gently palpate the joint space. The joint should move smoothly, without limitation, tenderness, pain, crepitus, locking, or popping.
Next, I'm going to check your salivary glands.
To finish examining the patient's head, inspect and palpate the salivary glands. They should be symmetrical, but not enlarged or tender. After taking the patient's history, measure her visual acuity, which tests cranial nerve 2, the optic nerve. To test distance vision, have the patient cover one eye and look at a Snellen chart that's 20 feet away. Ask her to read the smallest line in which she can identify all the letters.
P-E-C-F-D.
Can you read anything on line 6?
Maybe, but the letters aren't clear.
Okay. Now cover your left eye with the card and tell me which line you can read clearly.
Line 5 again.
Can you read that line backwards?
D-F-C-E-P.
Now we'll do this again. Put your glasses on and cover your right eye with the card.
That would be line 8.
If you test the patient with and without corrective lenses, document the readings separately. Record the patient's visual acuity as a fraction. The numerator is the patient's distance from the chart, usually 20 feet or 6 meters. The denominator is the distance at which the average eye can read the line. For example, a reading of 20/25 means that the patient can read at 20 feet what most people can read from 25 feet away. In adults, average vision is 20/20.
Are you ready to play the E game? Yes. Good. Okay, Mom, if you could cover up one of her eyes.
For a child or an adult who doesn't read English, use a Snellen E chart to test visual acuity.
Good.
While you stand at the chart, have the child point her arms or fingers in the direction of the legs of the E.
That's right.
You may need an assistant, such as the child's parent, to help her cover one eye.
Now cover your
If the patient's distance vision is less than 20/20, Have her hold a card with a small pinhole over the uncovered eye and read the chart again. If visual acuity was reduced by a refractive error, this should improve acuity by at least one line.
TEC.
Next, test the patient's near vision with a Rosenbaum pocket vision screener held about 14 inches from the eyes.
Cover your right eye with the card and read the line with the smallest numbers that you can see clearly.
Normally, near vision is also 20/20 in both eyes, which should be tested separately with and without glasses.
428739.
Good. Now take off your glasses and we'll try it again. Now I'm going to test your peripheral
Next,
vision.
estimate peripheral vision with the confrontation
Look
test.
directly into my eye.
Position yourself
You're gonna
1
cover
meter
your
from the
right eye.
patient at
I'm
eye
gonna cover
level.
my left eye.
Have her cover her right eye while you cover your left eye.
Now, what I'm going to do
With your arm fully extended midway between you and the patient,
what I want you to
move
do
your
is
fingers
tell me as
in
soon as
from
you
the
can see,
superior,
okay?
temporal,
And remember to
nasal,
look straight
and
ahead.
inferior fields. If you have no vision problems, you and the patient should see your fingers at the same time.
Now.
Good. Now we're going to switch eyes and we're going to try it again. Remember to look straight ahead.
Usually this occurs at about 50 degrees superiorly, 90 degrees temporally,
Now.
Good.
60 degrees nasally,
Now.
Good.
and 70 degrees inferiorly. Next, examine the
Now I'm gonna
external
look at the
eye
outside of your
structures.
eyes.
To start,
Relax,
inspect the eyebrows,
straight ahead.
noting their
eyes
size,
open.
extension, and texture. The hair should extend beyond the temporal canthus and should not be unusually coarse or thin. Then inspect the orbital area, which should have no edema, puffiness, lesions, or sagging below the orbit. In an older patient, you may see puffiness caused by an age-related loss of elastic tissue. However, you should not see periorbital edema. In a newborn, the eyelids may be swollen or edematous from birth trauma, but should have no inflammation or drainage. Also inspect the eyelids.
Now, could you close your eyes for a minute, please?
When lightly closed, the eyelids should have no fasciculations or tremors, and there should be no flakiness, redness, or swelling.
Now open your eyes, please. Good, thank you.
On both lids, the eyelashes should have no inflammation or crusting. The eyelids should not be inverted or everted, and the lashes should turn up in the upper lids and down in the lower lids.
Now what I need you to do is open your eyes. as
Also,
wide
the
as you
upper
can.
eyelids should cover part of the iris, but not the pupil. The lids should be able to open widely and close completely, with no drooping or lid lag.
Okay, now I'm going to palpate your eyelids. Close your eyes for me.
Next, palpate the eyelids, which should have no nodules. Also, palpate the eyeballs, which should feel firm but not hard.
And now I'm going to check the inside of your eyelid.
Then inspect the conjunctiva of the
And
lower
look up for me,
lids.
please. Good. And I'm going to check the other eye.
When the lower lid is drawn down, the conjunctiva usually appear clear and free of erythema and exudates.
Let's see if I can find out what's irritating your eye. I want you to just relax. Look
Inspect the upper conjunctiva only if a foreign body may be present. While the patient looks down, gently pull the upper eyelashes down and forward and evert the lid over a cotton-tipped applicator. After inspecting the upper conjunctiva, ask the patient to look up while you press down against the eyelid.
Now, look straight ahead while I examine your corneas.
Next, inspect each cornea by shining a light tangentially on it. The corneas should be clear and have no blood vessels. In a patient over age 60, you may see corneal arcus or circus senilis, an arc or complete circle of pale lipid deposits at the periphery of the corneas.
Now, Mrs. Franklin, I'm going to touch your eyes with this cotton.
Also assess corneal sensitivity and cranial nerves 5 and 7, the trigeminal and facial nerves. The expected response is blinking.
Okay, let's try the other eye. Good. Now I'm going to examine your pupils.
Next, inspect the irides, which should match in color, and observe the pupils, which should be round, regular, and equal in size. Then dim the room to test the pupil's response to light.
Mrs. Franklin, I'm going to check the reaction of your pupils to the light. Just look straight ahead.
When you shine the light in the right eye, the right pupil should contract directly, and the left pupil should contract consensually. When you test the left eye, the opposite should occur. Also check for afferent pupillary defects with the swinging flashlight test. Shine the light in one eye and then rapidly swing it to the other. When the light crosses the bridge of the nose, the second eye should dilate slightly. When the light enters the second eye, that pupil should constrict as much as the first one.
We're going to do another test. First, I'm going to
Next, test the pupils for accommodation.
Then I'm going to have you focus on my finger. Look at the wall over my shoulder. Good. Now look at my finger.
The patient's pupils should constrict when she focuses on an object held about 10 centimeters from her nose. During all corneal tests, estimate the pupil size. When dilated, pupils may be up to 6 millimeters. When constricted, they may be as small as 2 millimeters.
Now I'm going to look at your lenses.
Using a pen light, inspect the lens, which should be transparent, and the sclera, which should be white, and visible above the iris only when the eyes are wide open.
As wide as you can. Now I'm going to examine your tear ducts.
Continue by inspecting the lacrimal glands and palpating the orbital rims near the inner canthus. The eyes should be moist without excessive tearing. The puncta should be pink and appear as slight elevations with no enlargement or discharge. Next, assess the extraocular muscles in the 6 cardinal fields of gaze.
And I'm going to ask you to follow my finger with your eyes. Okay?
The patient should display full movement, which reflects proper functioning of extraocular muscles and cranial nerves 3, 4, and 6, the oculomotor, trochlear, and abducens nerves.
Now follow my finger to your extreme left as far as you can.
In the extreme temporal positions, expect a few beats of horizontal nystagmus.
Now I want you to follow my fingers as far up as you can and as far down as you can, again without moving your head. Just follow with your eyes.
The eyes and upper lids should have smooth, coordinated movements. Next, perform the corneal light reflex test. At a distance of 30 centimeters from the light, the eyes should reflect it symmetrically, showing balanced extraocular muscles. If the light is reflected asymmetrically, do the cover-uncover test.
And you're going to stare straight ahead at my ear.
Look for any shift from a steady, fixed gaze in the uncovered eye. Then remove the cover and watch for movement in the just uncovered eye. You should see no movement in either eye. Finally, perform an ophthalmoscopic examination, giving the patient short breaks to rest her eyes from the bright light. If you wear glasses or contact lenses, you may leave them on for this examination. Patients should remove glasses, but may leave contact lenses in place. With the ophthalmoscope in your left hand and its lens set to 0, use your left eye to examine the patient's left eye, starting with the red reflex. For stability, place your right hand on the patient's forehead or left shoulder. Then direct the light at the pupil from 30 centimeters away. As the light hits the retina, you should see a red reflex with no black densities.
Now I'm going to come closer to your eye. Keep looking straight ahead.
Then approach the eye slowly, adjusting the ophthalmoscope lens with your index finger to focus on the details of the fundus or retina. If the patient is myopic or nearsighted, expect to use a minus or red lens. If she is hyperopic or farsighted, plan to use a plus or black lens. In a light-skinned patient, the fundus may appear yellow or reddish pink. In a dark-skinned patient, it may look much darker. Whatever the background color, you should see no discrete areas of pigmentation except for crescents or dots at the disc margin. Because you can really only see a small part of the fundus at a time, use the blood vessels as landmarks. Blood vessels branch away from the optic disc, so you can trace them back to find the disc. Then follow the blood vessels distally as far as possible in each quadrant. The arterioles should appear smaller, brighter, and redder than the venules, and the arteriovenous crossings should show no nicking or other changes. Next, examine the optic disc, which should be sharp and well defined, and may vary in color from yellow to creamy pink or darker. Use it as the unit of measure for locating fundal lesions or structures. For example, this lesion is 2 disc diameters from the optic disc at the 2 o'clock position, and the macula is about 2 disc diameters temporal to the optic disc.
Now look directly into the light.
This brings the macula into your field of vision. The macula should look like a yellow dot, surrounded by a deep pink area, and should have no blood vessels.
Great. Let's give your eyes a moment to rest, and then I'll check the right eye. Let me know when you're ready.
When examining the patient's right eye, switch the ophthalmoscope to your right hand and eye. As you did with the left eye, check for a red reflex, and then inspect the fundal structures, noting any lesions or other unexpected findings. Healthy eyes require the cranial nerves, extraocular muscles, and all eye structures to function properly. And you need expert history-taking and examination skills to assess all of them. With your examination findings as a roadmap, you can help your patient stay on the path to eye health or obtain the eye care that she needs. Beginning with the external ear, inspect the auricle's size, shape, symmetry, landmarks, and color. Also note the color of the surrounding tissue and check for any abnormalities. The auricle should match the color of the facial skin and should have no deformities, lesions, or nodules. The preauricular area should have no openings or discharge. Now assess the auricle's position. Draw an imaginary line from the inner canthus of the eye to the most prominent part of the occiput. The top of the auricle should be at or above this line. Next, draw a perpendicular line in front of the auricle, which should tilt back by 10 degrees or less. Also inspect the external auditory canal, which should have no discharge or odor.
I'm going to feel your ears now.
Then palpate the auricles and mastoid areas. The auricles should feel firm and mobile, and should be free of nodules. The mastoid areas should have no tenderness or swelling.
When I press back here.
For the otoscopic examination, select the largest speculum that will fit comfortably in the patient's ear.
Inside your ear now.
To straighten the auditory canal, gently pull the auricle up and back. With the opposite hand, insert the otoscope about 1 to 1.5 centimeters.
If you could just turn your head.
For the best view of the auditory canal in a child, you may need to pull the auricle down and back. For a patient of any age, Inspect the auditory canal, which should be pink with hairs in the outer third, but no lesions, discharge, or foreign bodies. You may see a little cerumen, which can vary in color and texture, but should be odorless. If cerumen blocks your view, remove it by irrigation or a cerumen spoon. In each ear, inspect the tympanic membrane, gently moving the otoscope to see the entire area. You should be able to see all landmarks, including the umbo, handle of malleus, and light reflex or cone of light. The tympanic membrane should look pearly gray and have no perforations. At the umbo, it should be slightly conical.
So I'm going to insert this
To
back
assess
into your ear
tympanic
and then
membrane
push
mobility,
off of air.
make sure the otoscope speculum fits well and seals the auditory canal. Then gently squeeze and release the bulb on the otoscope's pneumatic attachment. In response, the membrane should move in and out, causing a visible shift in the cone of light.
I'm going to whisper 3 letters or
Next,
numbers, and then I want
check
you
the patient's hearing with the whispered voice,
and to make
Weber,
sure that we're
and
testing
Rinne
one ear at a
tests.
time, I want you to take your finger and put it in your right ear and wiggle it while I'm testing the left ear.
Like this?
That's perfect. Now look straight ahead, please. 14.
At a distance of 30 to 60 centimeters, or 1 to 2 feet,
14.
the patient should respond correctly more than half the time.
C1V.
That sounds like C1V.
It is. That's good.
Next,
So far,
perform the
everything's
Weber
great.
test.
Great.
To begin,
do a couple of
tap
hearing
or
tests
stroke
with
the
the
tines of a tuning fork to set it in vibration. Then place the base of the fork on the midline of the patient's skull.
Let me know if you hear. And I want you to tell me when you stop hearing the sound.
Okay.
To assess bone conduction, place the base of a vibrating tuning fork against the mastoid bone and note how long it takes until the patient can no longer hear the sound.
Now.
Now I want you to tell me when you stop hearing the sound.
To assess air conduction, quickly move the vibrating tines 1 to 2 centimeters from the auditory canal. Note how long it takes until the patient can no longer hear the sound. Air conduction should be twice as long as bone conduction.
Now.
Now,
I'm gonna
with
be
the
examining
patient's
your
mouth
lips, and I'll need
closed,
you to keep your mouth
inspect
closed.
and palpate the lips. They should be pink, smooth, and symmetric, and they should have no swelling, lesions, or other surface abnormalities.
Okay, that's great. Now I'm going to be examining your mouth. I need you to give me a big smile and clench your teeth.
Next, examine the buccal mucosa, teeth, and gums. Ideally, the upper molars should interdigitate with the lower molars.
Very nice. Can you open your mouth now, please?
Next, inspect the oral structures using a tongue blade and bright light. The buccal mucosa should be pinkish red, smooth, and moist. The gums should appear slightly stippled and pink, with a clearly defined tight margin at each tooth. Also palpate the gums, which should be free of lesions,
hurt when I
induration, thickening, masses, and tenderness. Then use a tongue blade to probe each tooth, which should be firmly anchored. Note any wear, notches, caries, or missing or loose teeth.
Can you stick out your tongue and hold it, please?
Next, inspect the tongue. It should look dull red, moist, and glistening, and should have no coating or ulcerations. The tongue should protrude fully, remain midline, and show no deviation or tremor.
Now I need to look under your tongue, so please take the tip of your tongue and put it behind your front teeth.
Normally, the ventral surface of the tongue is pink and smooth, with large veins between the frenulum and fimbriated folds, but with no swelling or varicosities. In an older patient, however, varicose veins under the tongue are an expected variation.
Now I need to look at the sides of your tongue.
Wrap a piece of gauze around the tongue and pull the tongue to each side to inspect its lateral borders. You should see no white or red margins or ulcerations.
Okay, that's great. Now I'm going to feel inside your mouth.
Continue by palpating the tongue and floor of the mouth. The tongue should feel smooth and even in texture. And you should find no nodules, ulcerations, or areas of induration.
Now I need you to tilt your head back, open your mouth wide so I can look at the roof of your mouth.
Okay, I need to take a look in your throat with this.
If a young child resists the oral examination, ask a parent to hold her with one arm across her arms
Try to open your mouth.
and the other across her
Okay,
forehead
Mom, can you
to
help
restrain
out?
her
Just
gently
put your
yet
hand on her
effectively.
forehead and on her arms. That would be great. Okay, say ah.
Usually the whitish hard palate is dome-shaped, has transverse rugae, and smoothly meets the pinker soft palate, which extends to the uvula at the midline.
Okay, you can straighten your head up. Great. Now I need you to open wide and say ah.
As the patient vocalizes, the soft palate should rise symmetrically, and the uvula should remain midline.
Okay, that's great. Now I just need to look at the back of your mouth, so if you could open wide.
When inspecting the oropharynx, observe the tonsillar pillars and retropharyngeal wall. If present, the tonsils should be pink like the pharynx and shouldn't project past the tonsillar pillars. The retropharyngeal wall should be smooth, glistening, and pink, with small blood vessels and spots of lymphatic tissue.
The last thing I need to do is test your gag reflex. And this should
Using a tongue depressor, touch the posterior wall of the pharynx on each side. This should elicit a bilateral response. By using inspection, palpation, and a few special techniques, you can easily examine your patient's ears, nose, and throat. And by putting these findings together with the health history and diagnostic test results, you'll have a clear clinical picture that can guide your patient's health care effectively.
Okay, great. Now I'd like to examine your nose.
While inspecting the external nose, note its size, shape, and color. Normally the nose is straight with no deviations. The skin is smooth and unswollen and matches the color of the face. The columella is midline, and the nares are oval-shaped and symmetrical, with no discharge, flaring, or narrowing.
You can bring your chin down. Now I'm going to be pressing on your nose. Let me know at any
Next,
point.
palpate the nose, placing one finger on each side of the bridge and moving gently over the soft tissues down to the tip. The nasal structures should feel firm and stable, with no tenderness, masses, or bone or cartilage displacement.
When I block this nostril, try to breathe in and out through the other.
Then check the patency of the nares by occluding one at a time.
That's good. Okay, now the other.
Through the open nares, nasal breathing should be noiseless and easy. Continue by inspecting the nasal
With
cavity.
this.
Okay.
To do this, use one hand to move the patient's head, and the other to slowly insert the nasal speculum, stabilizing it with your index finger. With the patient's head erect, inspect the nasal mucosa, vestibule, and inferior turbinate. Tilt the patient's head back to see the middle meatus and middle turbinate. Then move the speculum tip midline to view the septum. The nasal mucosa should be deep pink and glistening with no discharge, masses, or lesions. The turbinates should be the same color, firm, and unswollen. The septum should be midline and straight, with no perforations,
Now I'm going
bleeding,
to
or
check your
crusting.
sinuses.
Next, inspect the frontal and maxillary sinuses, which lie above and beside the nasal cavities. You should see no swelling. In a child under age 7, the frontal sinuses may not be developed yet, so focus your examination on the maxillary sinuses.
Maybe pressing on your sinuses.
Also,
Let me know
palpate
if
both
any
pairs of
areas-
sinuses.
Okay.
For the frontal sinuses, press your thumbs up against the brow bones.
No, that feels
For the maxillary sinuses, press up under the zygomatic processes. There should be no tenderness or swelling.